Welcome to the Rehab Remix.
Where we break down the hottest topics in ortho and neuro PT to help you elevate your clinical game. We're your hosts, Dr. Lauren Tighe
And Dr. Lauren Young, bringing you practical insights straight from the evidence to your earbuds. You know what time it is. The mic is on, the vibes are right, and we're diving back in. This is where research meets real life and voices from the field bring it all into focus. Put your headphones on. It's time to remix. And today we have Dr. Jimmy Pang. Dr. Pang, would you like to introduce yourself to our listeners?
Hey, good afternoon. My name is Jimmy Pang. I'm a physical therapist here in San Diego, and I've carved out a little niche for myself in vestibular disorders as well as headache disorders. So migraine is probably one of my favorite things to treat. So I'm really excited to dive deep into that subject today.
Well, we're so excited because we want to talk all things migraine. So, like you said, that is I think vestibular is a very specialized area in PT. And then you pull it into migraine. I know there's a lot of conversation right now surrounding vestibular migraine. That's, I feel like, a hot topic. But what piqued your interest in that specialization, specifically migraine?
Well, I think getting into migraine was definitely a big part of it was probably my own lived experience with migraines. So just kind of looping into that, I became a migraine patient about 6 years ago, and I actually present with an atypical presentation. So I think people who might not be familiar with migraine, or some people, when people think of migraines, they typically think of headaches. And then if you're a little more familiar with migraine, you might think about things like sound sensitivity, light sensitivity, right? But I fell into this very unique category where I didn't really have the signs, but actually during my first attack, it actually presented with ataxia. So yeah, so my diagnosis, I've had several, but I think the one that lands the most is a atypical migraine variant with episodic ataxia. That definitely piqued my interest in migraine because it became my life. I had to stop working for a couple of years. And then through a lot of therapies, a lot of different treatments, I was finally able to get to a point where I could finally work. So I think that's what largely drove my interest into migraine. Part of it was also by necessity. I was always more partial to neuro, but when I became a chronic pain patient, and then it's not just the migraine, there's other body parts too. And they floated the diagnosis of fibromyalgia out there too. So I always liked neuro, but it got to a point where I couldn't really handle, stroke patients, patients that needed a lot of physical assistance. So it was also driven by necessity. When things started going south, I knew I had to change, but I also knew that I didn't want to go into ortho, that's for sure. So the next logical step was vestibular, and then by extension, ended up in this world of headache.
Wow, that's an incredible story, to have been on the other side of it. Prior to experiencing these migraines, did you know that that was something physical therapists can treat? And I think I've seen on your social, you've talked about having a team, approach. So who all did you go to? Who are your go-to specialists when you have a difficult case of treating someone who has a migraine?
Yeah, that's a great question. I think it's largely dependent on the individual, but I think physical therapists, we have a pretty large role to play, and we're actually highly underutilized. But I think if you're a migraine patient, 100% you need a neurologist on board. I don't think there's really a way around it. Not everyone's going to need pharmaceuticals, but I'm a big believer that pharmaceuticals have a large role to play in migraine management. So, but as PTs, we have a pretty large tool set. I would actually say, I am on some migraine preventatives myself, but I would actually say the things that actually led to the biggest change for me were in the end still various therapies. So physical therapy, vision therapy, vestibular therapy. And migraine is interesting in that it has both orthopedic and neurological components, even though it's a neurological disorder. And you're going to find a lot of different impairments across different systems. So to be a migraine specialist, you actually need to be a pretty good generalist, I would say, because you need to be thinking about all these moving parts and how to go about it. And then I think occupational therapy is also really big for migraine, learning how to live with this highly disabling disorder. I think occupational therapy plays a good role. And, brain fog is also a big part of migraine pathology. So maybe considering if someone has a lot of problems with executive functioning due to their migraine disorder, it might even be worth looping in neuropsychology.
That's like a diagnosis that provides the ability for so many specializations to kind of come together. And I think it's crazy to me because I would venture to say, and you can tell me if you feel differently, that there are not a lot of places where you can get comprehensive care for a migraine. Think that like I live in a very small town. Well, it's not very small, but it's limited in access to medical care. And I don't know that there's a neurologist within probably 200 miles of me who would know what to do with a migraine from some of the more recent evidence and research because it has improved in the last, I would say, 5 to 7 years to talk about us being able to treat some of these conditions. So it's a nice, I guess, diagnosis where hopefully all of us are able to use this multidisciplinary model, but it almost sounds like you have to have that because you need some of the medical management, you need some of the physical care, you need the occupational piece that can help you with some of those other things.
Yeah, absolutely. I think it's very hard to find a comprehensive team. I'm lucky enough that out here, I think I've built a bit of a network that I could point people to the right direction, but there are very few places where you're going to find a very cohesive place where you go to one location and they have everything. I think it's pretty much non-existent. The only place I can think of is reactive physical therapy in Los Angeles, right? I think they've done a really good job of having a multidisciplinary team on board. Yeah.
They do a wonderful job. If y'all haven't checked out their Instagram, they've got amazing education clips, videos, and they kind of dive into more niche diagnoses, I would say, including migraine, post concussion. FND is a big one that they treat as well. Brilliant, brilliant therapists out there that I could learn a lot from. Why do you think that PTs don't know more about how to treat? Is it they don't have entry level education to feel comfortable treating? The continuing education not there? Why do you think this is so specialized?
I think just in the medical community across all disciplines, there is a very strong lack of understanding of migraine pathology across all disciplines, across everyone. I don't think it's not just PTs. I think most entry level healthcare practitioners across the board probably aren't prepared to treat migraine right off the bat. So I've met many headache fellows. So when you're a neurologist, you can further specialize into headache and then you can become a fellow headache specialist. And they are a lot more clear on what physical therapy can do for migraine patients. They're a lot more clear on just how much we can help. But even among neurologists, right? So migraine is the number one reason someone goes to see a neurologist. Migraine is the number one disorder. Even among general neurologists, and I can't make a blanket statement, but this is my own experience. I would say maybe half of them don't even realize that physical therapy is an option at all. A lot of them just unfortunately just leave it at pharmaceutical management and leave it at that. And then I think that the other issue is migraine is just such a broad diagnosis, this whole spectrum of presentations. So I think it's like I mentioned, you have to be very flexible when it comes to treating migraine. There's no CPG out there for it either. The research is still kind of lacking. And, I don't blame them because it's just there's too many different variations out there to make one CPG for disorder. So I think what we have to do is we have to look at the various kind of ways that headaches can present in people. And what we have to do is actually you have to borrow a lot of techniques from different disorders. So concussion CPGs, ergogenic headache CPGs. These are really great resources. So I think on the one hand, it's a little daunting. There's so many different ways it can present, and you have to be well versed in a lot of different things to be able to pinpoint your treatment. But at the same time, I think a lot of PTs, some of them already have certain tools in their tool belt that they could actually make a pretty significant difference. For migraine patients who have a really heavy cervicogenic component, they could actually do really well if they just saw an ortho PT who was really good at working in, neck and shoulder pain. It can make a world of difference for them, right? Or if someone has vestibular migraine or vestibular problems, they can go see a vestibular therapist and that can help a lot. And then, if they have more vision problems, right, then you can go see a vision therapist. But I think if you do want to venture into treating migraines, it's good that you say you're very strong in cervicogenic problems. You definitely still want to be exploring these other things. So when you become a migraine therapist, you're going to have to be a generalist and a specialist at the same time, if that makes sense.
Yeah, that actually kind of like circles back to my question that I wanted to ask you, Jimmy. Can you elaborate more on the importance of being a generalist as well? Because I think in our profession in general, there is this real big push to be a specialist. And I think that's great. But I also think sometimes when we push it so hard, it's almost like you're putting the blinders on and you're not seeing anything else. And so I love how you keep bringing back to the surface being a generalist and a specialist. And can you kind of dive into that a little bit more as it pertains to specifically migraines, but also just maybe your general perspective on that?
Yeah, so I always say that just because you're a specialist doesn't mean you get to stop being a generalist, right? Our patients, they're not textbook diagnoses, they're people, right? They're people with a whole host of things going on. So I think a lot of vestibular therapists are very familiar that vestibular patients don't like to move their head, they don't like to move their neck. A lot of them come in with cervical issues. If we're a vestibular therapist and they come in and we just kind of put our hands up and say, I don't work with neck. You got to go find someone else. Yeah, that's a huge barrier for the patient, right? Because they're already managing a lot. Migraine patients are already managing a lot. I think it's important. We have our doctorates. We went to school. We have a lot of tools under our belt, and I think we need to utilize the full breadth of tools that we have. We don't want to be doing a disservice to our patients by not even trying, right? If something's a little bit outside your comfort zone, I think another thing that's really nice about PT is we can afford to take risks more than other professions, right? Because everything we do is pretty low risk, exercise, things like that. So we have a lot to offer our patients, and the best way to learn is really by doing. So I think with these migraine patients, you want to be thinking about all the tools you have under your belt, and that's just how we serve our patients best. Don't get myopic. Yeah.
I like that. I appreciate that perspective because I think it also creates that window of opportunity to continually be curious and willing to grow in your field. And I think that's part of the reason why Dr. Young and I like started this podcast. We both come from two very different backgrounds, but we both also see the importance of being a generalist and being, like you said, not scared to try something that may not be like your quote unquote specialty or niche area, because it's most beneficial to the patient. So love that. My next question in talking to you and listening to some of your responses, what is one myth about migraines that you would just like either like to bust or just kind of like toss out? You're just like, okay, this is like the general consensus that people think about migraines, but it's like totally false.
So I would say not taking migraine seriously. A lot of times people just equate migraine to a bad headache. You hear it in language, right? Oh, I had a migraine. Sometimes people just chalk it up to a bad headache. And then I also think it's important to think about the language we use around migraine. So, and this is something I'm very guilty of still. Migraine is a neurological disorder. It's not something you get, right? We should be trying to move away from the language. I get migraines, right? Because migraine is a complex neurological disorder with a lot of different presentations. So I think migraine needs to be taken more seriously, both among healthcare providers and the general public. Migraine is actually the second leading cause of disability in the world. So just behind low back pain. It's the number one leading cause of disability in women under 50, right? So there is a very big portion of people out there who experience very high levels of disability, right? People who can't work, people who can't do the things that they want because of these headache disorders. And going a little bit beyond that, like I think I've touched a bit on it, on how migraine can be very broad. And so I just kind of want to get into some of the more obscure migraine diagnoses that are out there. So, we even have something called hemiplegic migraine. So people's migraine attacks come with hemiplegia. We have something called abdominal migraine, where people's migraine attacks come with abdominal symptoms. We have migraine people who have episodic ataxia, facial pain, visual auras. These are very neurological deficits, but when people think of migraine, they don't really think of these neurological things necessarily happening. We need better representation for migraine. So like I mentioned, migraine is the second leading cause of disability in the world. Yet migraine does not qualify for long-term disability in the United States. So this is a really big problem that we have. And I think I'm really on a mission to spread the word on that. So to kind of sum it up, migraine is more than a headache. Migraine is a very complex neurological disorder with a lot of different presentations, and it deserves more visibility, more representation, and we need legislation to convey that as well. So we need it to be a qualifying diagnosis for long-term disability in this country.
When you talk about like, presents with ataxia, it can present hemiplegic. These are all things, right, that mimic a stroke.
Hmm.
And so as practitioners, if we're seeing someone who maybe hasn't been to a neurologist, I can see why it would be a long road because we're identifying, hey, all of a sudden half of my body is numb. If there's a practitioner who looks at that chart and doesn't see that person has a history of hemiplegic migraines, I'm worried that they're not referring back to a medical provider if they're not doing that. So the first step, even if you were to get into a PT clinic, would be for us to refer back out. Typically, and you can talk from your patient's experience, your experience, how long does it take to actually get diagnosed with a migraine disorder? Like, how many times? I feel like it's in my world, what I've seen, it's a really long time.
Yeah, it takes forever. Trust me. I've been through it myself. I can't remember the exact number, but I think there's like a number out there where it takes on average like 4 to 5 different clinician visits before someone finally gets to the right diagnosis with a migraine disorder. And to the point of the hemiplegic migraine, yeah, I'm really glad you brought that up. That's a very, very rare presentation, but it does exist. And I think as PTs, yeah, absolutely. If we don't see that in the history, then you absolutely need to be referring out, treating it like an emergency. Yeah, so it is. I think the thing about migraine is there are a lot of red herrings that come with it, right? So the hemiplegic migraine, you know, already we're thinking about the stroke. But even so, I think a lot of times when people get presented with kind of these atypical presentations of migraine, like ones that come with a lot of facial pain, all of a sudden you're thinking about, well, could it be cervicogenic? Could it be TMD? All these different things. And oftentimes with migraine, it'll come together. So piecing everything together, getting a clear picture is very difficult. So it makes sense that it would take a long time, unfortunately.
And in that like time period, so if someone, which of course this is kind of a biased question because you work with people who have migraines, you're familiar with this, but for the lay person who isn't working with someone who has migraines, when you're talking to them and pulling that back in, are you comfortable treating like what I guess what are you looking for in your evaluation process that says, okay, I am relatively sure that this is a migraine that's presenting atypically? How would you feel comfortable moving forward if this person didn't have a diagnosis of migraine, but you highly suspected it?
If you are a migraine patient, you need to have a neurologist on board because you need to have the medical workup done to make sure that we don't have something more sinister going on. And with our PT eval, even if they have been cleared by neurology to come see you, I think we need to do our due diligence and screen. So making sure that we're not dealing with something that's more sinister than we thought. So, and these can be quick tests, right? Like a Babinski, a Hoffman, pronator drift test, very quick screens just to make sure that we don't have something we need to be more worried about.
So, Jimmy, the last question before we kind of move into some topics of like treatment, can you touch on the evaluative process for a new patient coming in with complaints of migraines? Like, what does that evaluative process look like from a clinician standpoint? What do you do in an evaluation?
So, with a migraine evaluation, we definitely need a very thorough history. Right? We need to understand if they've had the proper medical workup done. Migraine often comes with other disorders at the same time. Central sensitization is a huge part of migraine. So, people with migraine, they're often going to present with multiple things. And then from that history, you're going to get a good idea of where we need to focus. Migraine, since it's essentially central disorder, it presents with all kinds of um, deficits in different sensory systems. So we want to be listening to the history to clue us into which branch we want to really focus on, at least for the eval. So I'm thinking in terms of, so I'll give some examples. If I hear someone say, they feel like when they turn, they feel, actually, let me backtrack a little bit. So it's also going to really depend on how chronic they are versus episodic. So for the most part, I think PTs were going to be seeing chronic cases, right? So we know migraine, they tend to be phased attacks, but it's not true for everybody. I would say most of our chronic patients, they have spikes, but many of them are living with this general sense of unease and disorientation. So we need to figure out what systems are being impacted by their migraine disorder that are causing them to feel this way. So, if I hear someone has trouble with maybe screen time, reading, very high convergence demands, this is going to make me want to look at their, you know, ocular motor symptoms, convergence. If I'm hearing things like, they, when they're doing turns, they start to feel a little woozy, then I'm thinking, okay, more vestibular symptoms. And if it's coupled with a lot of head and neck pain, then I'm like, okay, this eval is going to be a little more cervicogenic in nature. But I think it's really going to come down to what you hear and then going off of that and then what you see. And then so this is where you need a lot of flexibility. We need to try to understand what we need to tackle first and going from there, see what's going to give us the most return and seeing kind of what is the dominant driver of the disability in the patient that's sitting in front of you.
So I mean, I feel like we could talk about this for like hours. I'm like so intrigued. I'm like sitting here like my mind just like in the zone. So if I look like I'm kind of glazed over, it's because I'm like so intrigued by all of the information. So that gives us a great foundation of why PTs should be involved in migraine care. So in part 2 of our conversation, we are going to dive into how physical therapists actually treat migraines and what clinical takeaways that you can have or give to our listeners. So that concludes part 1.
Be sure to sign up for our newsletter linked in the show notes. You can find me, Dr. Young, on Instagram at NeuroElitePT. And Dr. Tighe, where can they find you?
On Instagram as well at LTigheDPT. Thanks for tuning in to the Rehab Remix, where you listen in and level up. We'll see you next time.